Well, welcome to the colorectal session, and I'm glad we're pretty popular. I'm on the program committee, and they're making us take lots of pictures and post them, so I'm going to ask everyone to smile. Woo. I hope you're all having fun. This is a great session and a lot of excellent abstracts and a few videos, and we're going to, for lack of space or time, commit everyone to trying to stay on time and so that we can get to lunch. So without further ado, our first presenter, if you could start coming up, we are going to talk about level...
It's Matt Rawls presenting.
Oh, is it?
Yeah.
I didn't realize that. Okay. Matt Rawls, excellent. Level up, the impact of inflammation on rectal biopsy for HIRSCHSPRUNG's disease from the University of Michigan and Mott Children's Hospital. And I guess this is going to have to come off the, because it's listed for a Lopyan.
Oh, okay.
So that's just fortunate. Yeah.
Okay. All right, great. Thanks, everyone. Yeah, Dr. Lopyan couldn't make it today, so I'll pitch hit for her. Hopefully I can do as good a job as she would have done. We have no disclosures. So we noticed that every now and again we get a diagnostic biopsy for HIRSCHSPRUNG disease, and there is a level of inflammation reported. There wasn't really a standard way that was reported or looked at, and we didn't really know how to interpret that. So what we did is we looked back and wanted to describe the management and the outcomes of those kids with HIRSCHSPRUNG disease who had inflammation on their initial diagnostic biopsy. So we looked back over 10 years, included everybody who had definitive pull-through for HIRSCHSPRUNG disease. We excluded kids who didn't have 1-year follow-up who were inaccessible to diagnostic tests from outside hospitals. Our primary outcome was 30 days of complications after the pull-through, and this is a list of our complications. So we looked at 49 kids, 17 of which had some level of inflammation reported on the biopsy report, and 32 did not. If you look at the clinical evidence of enterocolitis, those with inflammation had a higher correlation to having inflammation on their biopsy. And then the way that we managed them over these last decade or so was more kids who had inflammation on the rectal biopsy were actually diverted before undergoing their primary pull-through. Whether that was from the biopsy or from their clinical presentation is unclear. So again, if we look at these side by side as far as perioperative outcomes, we found that having inflammation on your initial biopsy actually increased your risk of having an anastomotic leak at the time of pull-through. The other complications were not significant. So what we did is said, well, did the way that we managed these kids have any impact on that anastomotic leak? So of the 17 kids that had inflammation, we broke them down into those primary pull-throughs that were done within the first few days, or the ones who were diverted and then had a takedown and a pull-through done several months later. The idea of cooling down that inflammatory pathway or cooling down their colon. Interestingly, what we found is actually we had 3 leaks of kids who had a colostomy first and then had a pull-through, and 1 who had a leak during a primary pull-through. There was no significance noted with this, but again, it was an interesting finding for us. So in conclusion, inflammation on rectal biopsy for HIRSCHSPRUNG is associated with an increased risk of an anastomotic leak in our group, and the complication occurred independent of our operative strategy. And attention to methods to either mitigate inflammation or confirming that it has resolved may be of benefit. And further research is needed to standardize how pathologists would describe this and report it to the surgeons of record. Thank you very much. Happy to have a discussion.
Andrea Bishop, Children's Colorado. Congratulations. I think my concern is that correlation that doesn't mean causation. So you finding inflammation in a rectal biopsy just means that patient had enterocolitis prior to surgery. And most of the leaks are because of a technical problem. So I think you found the correlation, but that doesn't explain the cause of it. But what are your thoughts?
Yeah, it's a very good point. I agreed that most of these are a technical complication. However, you know, the healing may be affected by the inflammatory pathway. I'm not 100% certain. It's definitely a correlation at this point, but we thought it was an interesting finding.
Thank you.
Thank you.
Matt, were there any, I know it's a small group, but when you found the inflammation from the biopsy, what was the time frame between biopsy and pull-through? And did you attempt cooling those patients off with, rectal irrigations for X period of time and then doing the pull-through?
Yeah.
Are those variables mixed in there? And
It was pretty hard to kind of tease those out. We tried to look and see if we could, go back and say, yes, those kids had washouts for several days to weeks or whatever it was. That was hard to define. We do know that the average for kids who had a definitive pull-through without, was only about 4 days after their biopsy. The kids who had the diversion, then the average, I think, was 120 days or something like that as far as when they went to their definitive pull-through.
What was your antibiotic regimen?
A little bit different over the years. Active signs of enterocolitis are something like azocin to start, and then usually Flagyl after that.
Can you just go back to your slide where you broke it down?
This one?
Yeah, so these are the ones that had active inflammation.
Had active inflammation at the time, and then 7 of them were pulled through within the first few days, a couple days later.
Yeah.
And then 10 patients were actually diverted, whether, again, from a clinical standpoint or one of the surgeons in our group said if he ever sees it, he just will divert regardless of the
And on
scenario.
pathology, inflammation is what
Yeah, so that's our next step is
okay.
to have these blinded again and pulled back and have our pathologist relook at them. But neutrophilic infiltrates, of course not eosinophils, but just any evidence of inflammatory cells.
So just out of curiosity, when you're saying the leveling colostomy prior to pull-through, there is a cool-down period before you actually do your pull-through?
Yes. And those children, again, still had that anastomotic leak.
And the pathology on the pull-through at that point?
Yeah, so we didn't look at that either. So that's,
Right.
that's
Yeah,
another
that's
thing,
the-
is to say
Yeah,
whether
is there
there's active
still
inflammation
there or
yeah.
not? Okay. Great.
Uh-oh. Oh, he's going to sit down. He's tired.
There's a chair over there. Great, thank you.
Thanks,
All right,
Matt.
Thanks, guys.
So the next paper is from Children's National, presented by Laura say that again, sorry? Tiusaba. The Gonzalez hernia during a posterior sagittal anal rectoplasty, the historical context of a technical error that led to a helpful new technique. Thank you.
Thank you, and thank you for the opportunity to speak. I totally missed that the stairs were over there. But anyway, we were excited that there was an opportunity to submit history abstracts this time around. So this is more of a historical background and fun facts. So I just write, oh, that's good. I should just be able to click, right?
There you go.
There we go.
Good job.
Thank you. We have no disclosures. And the surgical management for anorectal malformations, it really evolved towards the second half of the 20th century. And it was in 1950. So again, these earlier methods for these repairs were mostly done through blind dissection, through a small perineal incision, and had significant complications such as persistent fistulas and damage to adjacent structures. It was this that led to the description of new techniques in the 1950s. So in 1950, Dr. Stevens described the sacrococcygeal approach with focus on the preservation of the levator anal musculature. It is through the disarticulation of the sacrococcygeal junction, and it was one of the first times that a pull-through was described while protecting the muscles that contribute to the sphincteric complex. Between the years of 1968 and 1971, Dr. Pena, here in the audience, trained at Boston Children's Hospital and learned the Stevens technique from Justin Kelly, another trainee at the time, and Stevens Fellow in Melbourne, Australia. It was in 1972 that Dr. Pena went to the National Institute of Pediatrics in Mexico City and became the surgical chief. And between the years of 1972 and 1980, he progressively increased the length of the perineal incision to improve the exposure. Fast forward to 1980, it was when that first posterior sagittal anorectoplasty, or PSARP, was presented at the Pacific Association for Pediatric Surgeons, PAPS, meeting in Colorado Springs. We know that the PSARP provided unprecedented exposure to the important structures, and with the help of the electrical stimulation, the approach guided a plane precisely down the midline. We know now, though, however, that staying perfectly straight during a PSARP was, and it's still not always easy. And Dr. Guillermo Gonzalez, one of Peña's trainees at the time, on occasion would veer off the midline, exposing the adjacent fat, as you can see in this picture. This technical error at the time became infamously known as the Gonzalez hernia. Fast forward many years later, this fat is actually and has been found to be useful tissue that is intentionally mobilized, as you can see here, to cover a posterior urethra. And what we found and how we use it now has been helpful in repairs of recurrent or acquired vaginal or urethral fistula, and it provides coverage to the anterior rectal space as a buttress against a repaired urethra or vaginal wall, and offers a well-vascularized bed to cover a difficult-to-heal area where the fistula had been. So this was, again, first published in 2014, and it gave Dr. Gonzalez a chance to be redeemed. These are a reference. Thank you. I don't know if there's any questions.
Any questions? I'll ask a question in the meantime. Do you have any data to actually support that it helps or fixes anything? It's a nice story, and I know we often put tissue between fistulas. Some of us maybe put pleura between the esophagus and the trachea when doing a T fistula repair, but some don't. And I'm unaware of any data to support whether this actually changes that outcome, other than a good operation and putting vascularized, even if you had a healthy rectum and a healthy vagina. Let's say you had a rectal vaginal fistula and you're doing a repair of that. Between those, if you bring down healthy vascularized tissue, would that heal anyway?
Mark Levitt, Children's National. Laura, that was great. Thank you. In answer to Jason's question, the paper that was referenced was 10 cases. Where it helped, we've done it about 15 more times, and it has solved the fistula in all cases. And it's sort of a plastic surgery idea of a pedicularized flap using fat. And the idea came to me because of the technical error from the Gonzalez hernia, which was infamously known as something you didn't want to do, and obviously you still don't want to do during a standard PSARP, but if you're doing a redo situation and you need tissue, it's a nice way to get some extra tissue to cover the posterior urethra and the posterior vagina. So in answer to your question, yes, it has worked very well.
Thank you.
Good job. My turn.
Yep.
Okay. The next presentation is by Hira Ahmad. It's the Antegrade Continence Enema alone for the management of segmental dysmotility in functional constipation. Papers out of Seattle Children's Hospital, Milwaukee Children's Hospital, Mercy, Kansas City Mercy, and Children's National in, Nationwide in Columbus. And I believe this is a PCPLC collaborative.
There it is, a mouthful. Thank you. Thank you for the opportunity to present our work. We're very excited to present this. So the purpose of this study is to determine if antegrade continence enema alone is an effective treatment for patients who have failed medical management and they have functional constipation and segmental dysmotility. This was a cross-sectional retrospective analysis from a multi-center registry of the PCPLC. We included all patients less than 21 years of age who had functional constipation. They had colonic manometry, which demonstrated segmental dysmotility, and they had failed medical management and had undergone an ACE. And then subsequent colonic resections were all performed. If they were performed at the participating or enrolling institutions. We excluded any patients who did not have at least 1 year of follow-up, and we excluded all patients who also did not, or who had simultaneous colonic resection and ACE at the time of their surgery. We included 104 patients from 6 institutions. They had an even gender distribution, and the median age at the time of the evaluation was 9.6 years. At 1-year follow-up, 96 patients, or 92% of these patients, were successfully managed with ACE alone. 8 patients needed subsequent resections. We then looked at the characteristics of the patients who underwent resection and found that the pelvic floor dyssynergia was a significant factor in patients who failed ACE-only management and needed colonic resection. In conclusion, in patients with functional constipation and segmental dysmotility, antegrade continence enema is an effective treatment modality at 1-year follow-up. Patients with pelvic floor dyssynergia on anorectal manometry are more likely to receive colonic resection after ACE, but this warrants further investigation. Thank you, and I'll be happy to take questions.
Andrea Bishop, Children's Colorado, thank you very much. Just going to point out on one semantics. It's not the antegrade enema procedure that it's the treatment. The treatment is the enema. So I think we don't want to perpetuate the idea that surgeons can do an antegrade enema procedure and that will take care of the patient. What takes care of the patient is finding the right enema. I know you know that, but it's just, I think it's important to emphasize.
Absolutely. Many different ways to administer the enema. ACE happens to be one. Absolutely. Thank you.
Hi, Pratima Nandavada, Boston Children's Hospital. Did you have any data on which segments were more commonly affected and whether that had any influence? And did all of the patients routinely have an evaluation for pelvic floor issues, or was that just in a subset that failed?
Yeah, great question. Thank you. The most common segment that was affected was sigmoid colon. And the resections that were involved the sigmoid colectomy in all 8 patients. To answer your second question, unfortunately, not all patients underwent an anorectal manometry prior to their ACE, which is definitely something that we should advocate for in these very complex patients.
So it's hard to say if any of the patients who succeeded also had a problem with their pelvic floor.
Correct, but just the subset of patients who did undergo anorectal manometry, it did show that ACE failed in the patients who did have pelvic floor dyssynergia.
Thank you. Really great presentation.
Thank you.
Thank you for that, Mark Levitt, Children's National. I think that Pratima makes a vitally important point. We didn't proactively figure out whether there's a pelvic floor problem, and I think retrospectively, many of those patients, even the ones they might have done better with the ACE, they might have actually not even needed a resection. And I just want to give Richard Wood a lot of credit and the GI motility team at Columbus who put all this data so nicely together. I think what it brings is a little bit of order to the chaos of the management of the intractable constipation patient. The gastroenterologists need to understand that a Malone is a good option for them, antegrade flushes, and it's vitally important to make sure that the pelvis has been figured out. And I can tell you, I, for one, have removed many sigmoids in my life, and many of those patients probably did not need the sigmoid removed had they been properly figured out from a motility and an anorectal perspective before.
I'd like to ask 2 questions here. This is a great paper. First, so should we change our algorithm? Is it really necessary to get colonic manometry prior to potentially doing a antegrade procedure? Because you're saying that if you don't need to do the resection anyway, so why do we need that information? That's one. And then my second question is, I think tagging on to what Dr. Levitt mentioned, is if we find anorectal manometry abnormalities, i.e. dyssynergia, do we treat that first before even going to any next steps?
Yes, I will answer your second question first. I 100% believe that patients who do have pelvic floor dyssynergia, that's a completely different problem, and that definitely should be addressed prior to them undergoing any surgical intervention. And there's a lot of great literature in the adult world, is now more and more in the pediatric world as well, that has shown that it's very effective therapy. To answer your first question, I think it's almost an academic practice too at this point to for us to know that if the patient does have a colonic problem, if it's a motility issue, what we've shown is it's the antegrade enemas or retrograde enemas. Any sort of enemas are helpful. We just don't know if the constipation from other causes would have the same effect or not. So I would still continue to advocate, and there's a lot of great people in the audience, so please correct me if you feel differently, but I would continue to advocate for a manometry study.
Can I?
Dr. Pena.
The colonic manometry and anorectal manometry, in the years that I work, I have great expectations about those studies. And later on, I found that they are completely useless as far as the medical treatment of constipation. And I expected that from the colonic manometry that the experts will tell us which bowel doesn't work, and so we can resect. Well, actually, I found no use for those studies. I personally don't recommend those studies. And if you allow me to talk about a little bit about the Gonzalez hernia, Dr. Gonzalez was the chief resident when I was the chief of surgery. And I allowed him to start the posterior sagittal operations. If you are very meticulous when you open posterior sagittal and you remain exactly in the midline, you never see that fat, ischiorectal fat coming in the field. So one day he was opening, I entered to the room and I saw the fat and I was very upset with him. And then, then this should never happen again. So the following case, I went into the OR and he already opened and I didn't see any fat, but I saw some 6-0 sutures. And that we call that the Gonzalez repair for the Gonzalez hernia. And then, by the way, the common denominator that makes fistula is when you damage the posterior urethral wall and damage the anterior rectal wall and leave both together. That's an invitation for a fistula. But in a good posterior sagittal operation, you're supposed to mobilize the rectum enough to be sure that you leave a completely normal rectal wall in front of the urethral suture, and you will not need any other maneuver to guarantee that the patient will not have a fistula. Dr. Gonzalez is a prominent surgeon now, a senior surgeon, by the way. Thank you.
Thank you, Hira. Great one. Okay,
My turn.
yeah, on your paper.
I'm introducing our paper from Boston Children's. Claire is going to, Ostertag-Hill is going to present on autologous buccal mucosa for primary and secondary vaginal reconstruction.
Good morning, and thank you for the opportunity to present our work. Are we able to get my slides up?
Oh, that one's done already. We're on this one. You gonna fill the space up? Tell more jokes?
I'm terrible at jokes, if anyone knows. A bad track record.
All right, thank you everyone for your
Now I
patience.
gotta get jokes up.
Pediatric surgeons, along with pediatric urologists and gynecologists, provide care to patients with a wide variety of congenital vaginal anomalies and post-surgical vaginal complications. These patients may require primary vaginal reconstruction in the setting of complex congenital vaginal defects, disorders of sexual development, and congenital vaginal agenesis, as well as secondary reconstruction in the setting of post-surgical vaginal strictures or stenosis. Multiple approaches have been developed, often utilizing donor materials, including free skin grafts, local rotational flaps, and vascularized intestinal segments. Each of these existing approaches has advantages, but also has significant disadvantages, so there continues to be a need for the development of novel procedures for vaginal reconstruction. Attention has recently been turned to autologous buccal mucosa as a promising alternative donor material for vaginal reconstruction, and today I will review our experience with this promising technique. A retrospective review of all patients who underwent primary or secondary vaginal reconstruction with autologous buccal mucosa at our institution between 2016 and 2021 was performed. To briefly review the surgical approach, a full-thickness buccal graft is harvested with care taken to avoid Stenson's duct. The graft is then defatted and fenestrated to encourage engraftment. If the patient presents with distal vaginal agenesis, we first mobilize the Müllerian structures and then utilize the buccal graft to anastomose between the native tissues, and this is shown in the image on the left side. For patients that present for a stricture repair, the stricture is first released, excess fibrotic tissue is excised, and the buccal graft is then placed, as shown on the image on the right side of the screen. For all procedures performed after January 1st of 2020, we place an intravaginal wound vacuum at the conclusion of the procedure. Postoperatively, our patients remain on bed rest for 1 week with a Foley catheter and the wound vacuum in place. On postoperative day 7, they are then taken back to the operating room for an exam under anesthesia with wound vacuum removal, vaginal dilation, and soft vaginal dilator placement. Buccal vaginoplasty has been successfully performed 14 times in 13 patients with a median age at procedure of 18.8 years. Nearly 2/3 of these patients had underlying distal vaginal agenesis, approximately 30% had a cloacal malformation, and 1 patient had congenital adrenal hyperplasia. Many of these patients had previously undergone 1 or more vaginoplasty procedures with various donor materials. 2 patients underwent creation of a total neovagina. 4 patients underwent minimally invasive vaginal pull-through with the buccal mucosa graft serving as an interposition graft, and 8 patients underwent stricture repair. Median operative times varied wildly based on the overall surgical approach. I do want to point out, however, that the time to repair a vaginal stricture was much lower when the procedure was performed by a multidisciplinary team compared to when it was performed by a single team. Postoperatively, 1 patient experienced bleeding from the buccal donor site requiring suture placement in the immediate postoperative period. Additionally, 1 patient developed a stricture at the anastomosis between the buccal graft and her native tissues, requiring a second buccal graft to repair her stricture. At their most recent follow-up, most patients were continuing to dilate regularly, with 1 patient remaining premenstrual, 4 patients menstruating, and 6 patients continuing on menstrual suppression. As shown in the image here, at 12 weeks postoperatively, the buccal graft becomes nearly indiscernible from the native vaginal tissues. In conclusion, buccal mucosa graft allows for decreased mucus production compared to bile graft and eliminates hair-bearing skin grafts. The early cosmetic and functional outcomes are very promising. Based on our experience, we have several technical considerations to point out. Patients can benefit from regular mouth exercises to avoid contracture, and leaving the buccal donor site open may reduce postoperative pain. Fenestration of the buccal graft and intravaginal wound vacuum promotes apposition of the graft and wound bed, thereby promoting graft healing and take. Additionally, employing a multidisciplinary team allows for simultaneous working with unique expertise by each team. We're actively continuing to follow longer-term outcomes. I want to thank our multidisciplinary colorectal and pelvic malformation center, including the departments of surgery and urology, for their support of this work. Thank you very much.
Any questions? While Payam comes up, could I ask a question? It seems, I have 2 questions actually. First, I noticed your age group seems to be all patients who are pubertal already, so do you have any requirements regarding that? And second, do you have a length requirement or restriction of how long of a gap or bridge can you use the mucosal tissue to go from your introitus to your tissue you're anastomosing to or bringing down?
Thanks for stealing my questions, Jason.
What?
Thanks for stealing my questions.
Oh, I read your mind.
I know, you do. We've known each other for a long time.
You want to ask your question first, and then she'll answer yours first?
Well, those were my 2 questions, actually. Same as Jason. So if you can comment on the timing and if you advocate waiting to do a reconstruction until postpubertal or teenage years, and what your thoughts on that are. And then also the size constraint in terms of, how big of a graft can you actually make, and is there a cutoff that you would not perform this procedure?
Sure.
Excellent work.
Thank you.
Hi, I'm Sadai from Davis.
All right, I will do my best to answer both of your questions. So both of you are correct and picked up very well on the fact that most of our patients are in the pubertal, post-pubertal age. And we do that on purpose. Post-operatively, we do ask our patients to dilate regularly, to vary at least the dilator at night, and if possible during the day as well. And we firmly believe that it's important that the patient participate in that, let's say, experience themselves rather than having their parents involved in something that is quite a sensitive matter. So we do have these discussions with patients and parents earlier on, but we do highly recommend that they wait until a time where the patient can participate. In terms of the second question, I'll go back to this picture briefly. So we typically harvest only one side of buccal mucosa. Theoretically, it is possible to harvest both sides and use 2 grafts to allow for a larger surface area coverage. But the other thing I want to point out is that we do make these fenestrations, and that actually allows a larger surface area to be covered. We don't have a particular ratio or number of fenestrations that we make, and so you can fenestrate this or make more fenestrations if you have a larger surface area to cover. I don't know that there's a specific number that we look at. I'll defer to Dr. Dickey if she has a different opinion on that.
You can get up to like 4 or 5 centimeters to cover for an interposition. So, I mean, before we started doing this, I would just pull the vagina all the way down so there was no interposition graft. But I think that was a little bit of a disservice because you're pulling a very short vagina down. So when we know there's a short proximal vagina, we'll pull it down to the pelvic floor and we'll make up the rest of the distance with an interposition graft to give the final result a decent vaginal length. But you can, I mean, we've made entire vaginas out of it, and it actually stretches over time.
How many people in the audience use this technique or have this as part of their armamentarium? A few. It's a fantastic addition to the toolkit. Dr. Shaw.
Don Shaw, Children's Hospital, Orange County. Belinda, so it sounds like you may be using this primarily instead of, say, an ileal interposition. So that's an interesting change. I'd like to hear, is there any more to say about that?
So having looked after some of the older patients now who have interposition grafts, most of the older women complain about the discharge from interposition intestinal grafts. So either it smells, it's foul, it's constant discharge. So we actually started sort of taking some of those intestinal grafts and placing buccal down, and we had some really happy people after that. And so that just led to, instead of doing it as a second stage or fixing a stricture, can we use the buccal graft primarily? And so this way, talking with our gynecologists, talking with our urologists who have experience for buccal for hypospadias, I think it hopefully offers a better functional result in the end. The problem with it is they do need to dilate. So until it completely heals, they need to do dilations. Otherwise, the buccal graft sometimes will stricture down.
Dr. Velasco.
Christine Velasco, Phoenix Children's. We also use this technique frequently, and you discussed the site itself, that closing it makes more pain. Correct? You were saying that you think leaving it open generates less pain?
Yeah, exactly. So we didn't specifically look at that outcome, but in the urology literature, and the urologists use this quite frequently for complex urethral reconstructions, they have looked at this, and in their experience, patients, when the site is closed, they do have more pain. So our standard practice is to leave the site open.
So I ask that because our last patient we also do a multidisciplinary approach, and we had urology, gynecology, plastic surgery there, and the plastic surgeon actually felt that it caused more pain to leave it open. And our patient's biggest complaint after a vaginal reconstruction, including a rotational flap, was her mouth pain. So I find that interesting, the difference in the two fields. That
We now have our
saying
next
that.
study.
So
Just due to time, I think we're going to have
Nice
to stop the
presentation.
questions and keep going. But great presentation.
Thank you very much.
This is yours too. Oh, wow, you're popular. Next presentation is the utilization of emergency department services by patients with Hirschsprung's disease, presented by Timothy Tirrell out of Boston Children's Hospital.
Good morning, and thank you for the opportunity to present our work. We have no disclosures. Now, Hirschsprung disease needs little introduction to this audience, and we understand that care of these children does not end with their pull-through. They often experience ongoing challenges with soiling and motility problems and are followed long-term in our clinics. But these challenges don't end when these kids are no longer kids. Extending into adulthood, they have lower bowel function scores, and there's a paucity of adult providers who are comfortable with the intricacies of their condition and are comfortable adopting long-term care and management. In an attempt to understand the burden of this problem, we sought to evaluate emergency department visits by patients with Hirschsprung disease, hoping that by looking at patterns and trends, we might come to some understanding of how to frame conversations about transitions of care, understand components of resource utilization, and potentially gain information about how to mitigate needs for emergency department visits. We utilize the National Emergency Department Sample, which is a database that captures all clinical encounters for a set of just under 1,000 emergency departments, depending on the year. Basic demographic and clinical information are abstracted from each encounter, and one thing that's relatively unique about this database is that it is designed to be a cross-sectional evaluation of the United States. So using weighting information from each hospital, we can generate national-level estimates of clinical encounters. So we evaluated patients with a diagnosis of Hirschsprung disease who were seen in the emergency department across an 11-year time span, with a primary outcome of admission to that same hospital. Here's some demographic information, and I'll just direct you to a few things. One, over this time period, there were approximately 57,000 emergency department visits across the United States, about a 2-to-1 ratio between pediatric and adult patients. And for any given emergency department encounter, there was a slightly less than 50% chance of admission. Now, if we look at how this is evolving over time, this graph depicts total visits in white, adult visits in light gray, and pediatric visits in dark gray. And overlaid on this in blue is the percentage of total visits that are attributable to adults. And although it can be difficult to draw any conclusions just by comparing one year to the next, by evaluating a large time span such as this, we can begin to understand and appreciate not only that total visits are increasing, but the percentage of visits due to adults are increasing as well. We next wanted to understand factors associated with admission, so performed a logistic regression for a variety of factors. And I'll, again, just call your attention to a few things here. Not surprisingly, the presence of dehydration was associated with an increased likelihood of admission with an odds ratio greater than 4. Urban teaching hospitals also had a higher likelihood of admission, which I think likely represents concentration of medically complex patients at these types of institutions and are likely associated with admission as well. But I think this does provide a good example of an actionable item. If we can better manage and mitigate dehydration during acute illnesses, it may be possible to reduce the emergency department burden and subsequent admissions for these patients. Further work to find other such covariates that are intervenable may prove fruitful down the line as well. We also briefly evaluated charges in trends in ED charges for these patients. This graph demonstrates median and interquartile ranges year by year for these patients. And you can see that even after adjustment for inflation, over the period of time, the emergency department charges are increasing as well, resulting in a nearly doubling of charges for these patients. In conclusion, we think that adult providers need to be more familiar with Hirschsprung disease, as the total number of adults seeking emergency care are increasing, And these patients are having more and more difficulties finding adult practitioners that are willing to adopt their long-term outpatient care. We also feel that identifying factors associated with admission and presentation to the ED and developing strategies to mitigate those factors may reduce the need for emergency department services, as well as the financial burden on the patients, their families, and the healthcare system in total. Thank you for your attention. Be happy to take any questions.
Andrea Bishop, Children's Colorado. I found it fascinating that you have so many adult patients with Hirschsprung disease in the ED, because my impression is that enterocolitis decrease, which is the most cause for admission. So was there a cause for why they presented in the emergency room?
One of the limitations of this database is there's relatively little actual clinical information. This is all abstracted from ICD-10 codes. So one limitation is that if a Hirschsprung patient comes to the emergency department with chest pain, it does not differentiate that.
Okay, thank you.
Do you know, you mentioned, I think you said slightly less than 50% of the patients that were showed up to the emergency room were actually admitted for patients with Hirschsprung. What's the national average for patients that don't have Hirschsprungs? Is that standard, or is the Hirschsprung's patients significantly higher risk, or not risk, but rate of being admitted to the hospital?
It depends, not surprisingly, based on age and comorbidities, but I don't have a close comparator for the generalized emergency department as a whole.
And do you have a reason why we think so many Hirschsprung's patients are being admitted to the hospital? I know you don't have diagnoses, but just from a speculative standpoint, when I read this initially, I'm like, are we scaring our patients so much about Hirschsprung's enterocolitis that they just show up to the emergency room every time they pass gas or have a low-grade fever?
I don't have a great intuitive sense or information that can be gleaned easily from the data. What I think this study is most useful for is understanding on the large scale the things that may be worth investigating further. You know, these, part of the exam, you know, for example, looking at dehydration, part of the reason it's difficult to look at other covariates across this time frame is because of the change in ICD coding from ICD-9 to 10. But if you look at a more selected group, just say a couple of years, then you can dive in more deeply into those types of diagnoses.
Yes, sir. Through many years of practicing with Hirschsprung disease, I remember that I literally rescue little babies with enterocolitis in an emergency room at children's hospitals, where the pediatricians don't know the difference between enterocolitis and gastroenteritis. They think it's the same thing. And I rescue patients with severe enterocolitis that actually were diagnosed in the emergency room of a children's hospital. They were diagnosed as intussusception and intestinal obstruction, but the pediatrician did not suspect enterocolitis. As a consequence, we decided to make the mothers of our patients with Hirschsprung disease, after a pull-through, we showed the mother how to do rectal irrigations, and we made the mothers paranoid against enterocolitis. It was Friday night. The child becomes distended, is vomiting, and she decided to go to the hospital. We said, before you go to the hospital, do an rectal irrigation, which is a life-saving maneuver. And when you arrive to that hospital, call us immediately, because the people in the emergency room, even pediatricians, don't know how to make this diagnosis. We have to communicate more with the pediatrician to be sensitive about that serious complication that still kills a lot of children.
Yeah. And I think, as previously mentioned in one of the other talks, a lot of the care is delivered outside of the bounds of a specialized hospital where they are familiar with these kinds of complications.
Thank you very much.
Yeah. Next paper is out of University of Michigan Mott Children's Hospital. Do preoperative factors predict success of antegrade continence enemas in children, presented by Jack Vernamonte.
right, thank you for the opportunity to present our work. We have no disclosures. Oh, here it is. Got it. Sorry. Constipation and continence exist on a spectrum and affects up to 13% of all adolescents and children, may be functional or associated with congenital anomalies. Medical management is successful in most cases. However, in refractory instances in patients, surgical intervention may be required. One of the more common surgical interventions as an adjunct to a bowel regimen is the antegrade continence enema or ACE procedure. However, in these patients, identifying those that are going to be successful or not with the procedure can be difficult, and this knowledge gap would be helpful for both providers and families in counseling. Our hypothesis for this gap is that one or more predictive preoperative tests or patient factors could be predictive of ACE success. To answer this question, we did a single-center retrospective chart review from 2015 to 2021. Our primary outcomes was family satisfaction assessed at 3, 6, and 12 months post-procedure. Family satisfaction was captured using family self-reporting to an internal standard set of questions that included some based from the Vancouver and Rome scales at follow-up visits. We felt that family satisfaction was the best metric to assess in a widely heterogeneous population where objective criteria such as frequency of accidents or soiling may not reflect a change in quality of life after the procedure. Secondary outcomes were surgical complications, elimination or number of enteral bowel medications, a stable enema regimen, and additives. Variables were preoperative medication regimen, underlying etiology, and imaging workup. Oh, wrong arrow. We identified 43 patients who met inclusion criteria, of which 65% were male. The primary etiologies were idiopathic constipation and anorectal malformation. 91% in our center had an appendicostomy tube for the ACE procedure. Preoperative medications, the majority were on polyethylene glycol or Senesides as the primary medications. 63% were on 2 or more enteral medications preoperatively, and about half were on a home retrograde enema program prior to the procedure. Everyone for our institutional workup got an abdominal radiograph. 23% had colonic transit time, 19% had a contrast enema, and 12% had an anorectal manometry just for this procedure. The other things that were in our bundle were all patients had 12 months of medical management prior to surgery. If you had idiopathic constipation and no prior biopsy, a suction rectal biopsy was done, and behavioral health and developmental consults as well. For our primary outcomes, this is this family satisfaction at 3, 6, and 12 months. We noticed it was overall pretty good at 87% at about 6 months and stayed that way, maintained at 12. For secondary outcomes, there was no predictive effect or association with underlying etiology, as well as our preoperative tests or the type of enteral medications that they were on. This is a graph that shows the number of enteral bowel medications that patients were on preoperatively and then at 12 months post-ACE, either 0, 1, 2, or 3 or more. We saw a trend towards decrease at 12 months, with 63% of patients being on 2 or more prior to an ACE procedure, and that was able to go down to 6% at 1-year follow-up. We did see a significant difference in patient family satisfaction based on whether or not the patient and family were doing a home retrograde enema program prior to the procedure. Shown here in blue are the combined family satisfaction rates. Orange are patients that had a home enema program prior to the operation, and gray were patients that did not. Across the follow-up time points, families were more satisfied if they had a preoperative home enema program, and it was statistically significant at 3 months, but was not significant at 6 or 12. So in conclusion, this is a small single-center hypothesis-generating study, but overall family-reported satisfaction after ACE was high. It peaked at about 6 months with 87%, and that was across all underlying etiologies combined. Preoperative retrograde enema may predict early satisfaction at 3 months, but this was lost at 6 and 12. Further study on whether this is due to the fact that patients are familiar with enemas or the routine around sitting on the toilet or families with mixing it or other factors is warranted in a prospective fashion. Thank you, and I'm happy to take any comments or questions.
We'll just ask one question. The patients that had the retrograde enemas, was there an association with diagnosis?
No, they were evenly distributed across, or not statistically different.
In the interest of time, we'll keep going.
Thank you.
Thank you.
Oh, thank you very much.
The next presentation is entitled Indocyanine Green Fluorescence Angiography in Pediatric Intestinal Resections. This is presented at a St. Justine Hospital in Montreal by Nelson Pichet.
Pichet, perfect, thank you. Good morning. Before I start my presentation, I'd like to have just an idea with a show of hands. Who in the audience here uses ICG for bowel resection? Okay, and for oncology purposes, is there a little bit of a use as well? All right, great. Okay. I have no disclosure. As you all know, there's good evidence supporting the use of ICG for bowel resection in adults, and it is used with more and more frequency in the pediatric populations for various diagnoses. However, this technology is not approved by Health Canada for bowel resection. So to overcome that, we decided to create a little study to document the safety, feasibility, and acceptability of this technology for bowel resection in children. So we created a prospective mixed method study with a non-objection letter from Health Canada, and we included children 16 years and younger who required open bowel resection between the first year of the pandemic, from May 2020 to March 2021. To address each of the outcomes or the objective of the study, we created some specific outcome measures that you can see here on the slide. And we also had a secondary objective, which was to look at the potential impact of ICG on the bowel resection sites and lengths. Here you can see our intraoperative protocol step by step, including our dosage regimen, but in a summary, we compared the potential resection site using standard assessment and using ICG assessment. The potential resection sites were decided and marked by the surgical team, but the differences in the sites were measured by the research team. Ultimately, resection sites were decided by the attending surgeon. We included 28 patients, and we analyzed 30 procedures, and as you can see, the diagnoses were quite varied, but a significant proportion of our patients were HIRSCHSPRUNG's baby and neck babies. The age range of our populations ranged from 5 days to 15 years, but almost 90% of our patients were younger than 5, and half of our patients came from the NICU, and half of our patients, or half of our cases, were done on an emergency basis. I will now go over the results for each of the outcomes studied. Regarding feasibility, we had a very good consent rate, and fluorescence was achieved easily and quickly in all of our cases. Regarding safety, there was no adverse event related to ICG in this study. For acceptability, using qualitative research techniques, we created a mixed convergent method survey that included a Likert scale and open-ended question that was given right after the procedures to the surgeons, the fellows, the nurses, and the anesthesiologist. We had a very high response rate, and the vast majority of respondents felt that ICG use was technically very easy, that didn't have any complexity or delayed our cases. Interestingly, surgeons and anesthesiologists felt really good about using this technology during neonatal emergency cases. Now for the potential impact on resection sites. When looking at our entire cohort, when we compared the standard assessment versus the ICG assessment, there was a difference in 62% of our patients, and the mean difference in resection lengths, potential resection lengths, was about 2.5 centimeters. And these observations were similar when we looked at patients less than 5 kilos. I say potential resection sites because ultimately it was the surgeon who decided where the resections were done, and that led to a change of plan for only 2 cases in our cohort of patients, and both patients did very well postoperatively. So in conclusion, and this will not be a surprise for the audience, we consider that ICG fluorescence technology is safe, even for small babies, feasible technically, and readily acceptable for the entire OR team for pediatric bowel resections. Actually, we feel that our study brings more questions than answers, namely, what are the appropriate doses? How do we subjectively assess the fluorescence? And finally, can it truly impact the outcome of our patient when we use this technology? Thank you.
Nelson, thank you for that great presentation. You and I both share a passion about this, but Can you make a comment? I know when we published on it a couple of years ago on Hirschsprung's pull-throughs, we found that over 60% or almost 2/3 of the patients that we were operating on where we thought our line of transection should be based on vascularity was completely different than where ICG showed. Can you make a comment about what you guys found in your patients?
Yeah, the rate of differences was a bit lower because the study was really built to document the feasibility, safety, and wasn't really built to look at the impact on resection sites. So we had patients that came in, and the level of suspicion that the ICG would change anything was very low. So if you're going to do a ileocecal resection for something that has nothing to do with vascularity, of course it's not going to change very much. But especially in Hirschsprung's baby, I think a lot of the cases we would have changed our sites of resections, but it was a bit new for us as well to use this technology. And I think now that we're more used to it, I think it will have more frequently an impact on where we resect. We will trust the technology a bit more than we used to.
Great. Thank you very much.
Our next paper is once again from Children's National, Laura Tiusaba, Sparing the Perineal Body, a modification of the posterior sagittal anal rectoplasty for anal rectal malformations with rectovestibular fistula.
It's a video. I don't know if it's uploaded.
Yeah, it's a video.
Yes, thank you.
We present a case of a patient born with an anorectal malformation and a rectovestibular fistula. Examination of the baby reveals a normal introitus with the rectum ending as a fistula in the vestibule and a pink sphincteric ellipse. For females with an anorectal malformation, the options include 1, a rectovestibular fistula, 2, a rectofourchette fistula, 3, a rectoperineal fistula, 4, a rectoperineal fistula where the fistula is within the sphincter complex but at the anterior-most extent, 5, an anal stenosis, and 6, the anatomy can be slightly anteriorly located but normal. In females with an anorectal malformation, it is vital to inspect for Mullerian anomalies. Here you see a vaginoscopy which shows a normal vagina and a single cervix. The associated Mullerian anomalies one needs to be worried about include a vaginal septum, distal vaginal atresia, and a variety of uterine anomalies. The traditional PSARP is done in prone position with cutting of the perineal body down to the vestibular fistula, incising a posterior sagittal incision, mobilizing the rectum off of the posterior wall of the vagina, and then repairing the perineal body before completing the anoplasty and closure of the posterior sagittal incision. The operation we showed today with the perineal body sparing technique begins by re-demonstrating the anatomy. Here you see the clitoris, the introitus, and the vestibular fistula. The sphincteric ellipse is more pink, and the electrical stimulator can define its extent. This stimulator is the same one used by our anesthesia colleagues for their train of 4. Remember, muscle relaxant must be avoided. Here you see us marking the sphincter. The entire incision need only be the extent of the sphincter. No posterior and no anterior incision is needed. We are opening the incision in the midline. We use Lone Star pins to gain exposure. And we continue our dissection posterior to the rectal wall and replace the pins deeper. Here you see the rectal wall nicely defined. Note that the perineal body has not been incised. Sutures are placed in the rectal wall on either side of the midline, and the rectal wall is divided so that the anterior aspect can be easily seen. Sutures are now placed full thickness in the rectal wall. These are used for circumferential traction. The lateral aspects of the rectum are dissected, taking great care not to injure the vaginal wall to which it is intimately attached. The lateral dissection helps define the anterior wall dissection. The rectum is lifted off of the area of the rectovestibular fistula. And here you see the vaginal side of the fistula being dropped down. Now the rectum is full thickness and can be fully separated from the posterior vaginal wall. The dissection continues until an areolar plane is reached, which represents the location where the two structures, rectum and vagina, are fully separated. The perineal body muscles are sutured together where the fistula used to be, and this will form the sphincter anterior to the new anoplasty. In this technique, no sutures are needed in the perineal body skin. The anoplasty is now formed and placed within the initial incision into the center of the sphincters. The rectum is split on its anterior and posterior walls, and the anoplasty completed with 16 absorbable sutures. These sutures are placed full thickness, rectal wall to anal skin. And the final result. We have performed this new technique, a perineal body sparing modification of the traditional PSARP, in 4 patients with excellent results.
Laura and Mark, thank you for bringing this as a video, because I've talked to Mark about this, and I don't think I would have been as much of a believer had I not seen the video. So it looks like a straightforward technique that's a nice advance and won't have any problems with perineal separation. So thanks.
I'll ask a question if anyone else has any. Is there any concern about muscle stretching? You know, it's a little bit of a different exposure than we do use Wheatlanders to spread, but you've already split those muscles. Now those muscles aren't split, so you're stretching them. So any considerations to that time limit of how quickly we should be doing this?
Yeah, I don't think so. I think the, I'm sorry, Mark Levitt, Children's National. I don't think so. I think the Lone Star actually gives you some pretty elegant traction without a lot of tension. The key here is to, obviously, to preserve the perineal body skin, but what I recognized is the deep dissection to get the fistula out, cut through. That's not necessary because the muscles pretty much stay adjacent to where the fistula had gone, and then a single stitch repairs that muscle. So at the end of the case, the perineal body is completely untouched. I actually think it's less stretching than the Wheatlander, and also there's no incision posterior to the anoplasty. Now that usually wasn't much of a problem as far as dehiscence. It's the perineal body that we most feared. But at the end of the case, there's no incision at all. It's just the anoplasty itself. And I think that's why I think it's going to reduce, I anticipate it's going to reduce complications.
Any perioperative, Mark, any perioperative complications? I mean,
Yeah,
the whole point of this is to limit perioperative complications.
Yeah, we haven't had, again, we've done this only 4 times. I think it's an important technique to bring to APSA. We don't have long-term results. The 4 patients have done extremely well, and it's been more than 6 months. We actually are feeding the patients earlier because there's no incision to heal. So actually on breast milk same day, and many of them have been discharged post-op day 1. So I think that's an improvement as well.
And as they grow older, we'll be able to assess continence and just kind of go from there.
We've been doing this probably for about 3 or 4 years. We have up to 10 patients which we've done this way, and the actual results are actually quite nice. I think the whole point of saving that perineal skin helps with the healing, and it's the same thing.
Thank you.
We haven't had any issues.
Matt Rawls from Ann Arbor. Some of the surgeons in our group who have a little more experience and more gray hair than I have been doing something they refer to as a POTS, where it's essentially to kind of prevent the stretching of the sphincters, we'll just dissect down on the fistula and then make a small incision only, again, where you're making your incision. So I wonder if that's, again, something to prevent any kind of stretching of the sphincters. What are your comments on that?
I thank you for that comment. That is essentially a vitally important procedure that we looked at. But I think the value of the PSARP is so important for a number of reasons: the prone positioning, the visualization that you get, and probably most importantly, you have to separate the rectum from the vagina. And what I have seen in patients who have undergone the POTS anoplasty is the anterior rectal dissection was inadequate and pulled back and retracted and was left the patient with a stenosis or a dehiscence. So the nice thing about the PSARP, which we haven't given up at all, is to see that space between the anterior rectal wall and the posterior vaginal wall. And the POTS anoplasty doesn't do that, and the ASARP doesn't do that either. So what I wanted to do is keep all the wonderful value of the PSARP, and I can't thank Dr. Pena enough for that incredible advance, but try to eliminate the complication of the perineal body dehiscence, which is really what is the cause of most of the redos that are necessary.
Thank you. Mark, don't sit down. You could come back up. Are you presenting the next one, I believe?
Yeah.
Yeah, so the next presentation is early results of a novel technique for anal sphincter reconstruction to treat overstretched sphincters following a pull-through for Hirschsprung's disease, presented by Dr. Levitt from Children's National Hospital.
Also video.
We present a 10-year-old boy with a prior pull-through for Hirschsprung's disease. He suffered from fecal incontinence for many years, and when I first met him, after being referred from another institution, the exam showed a patulous anus and an absent dentate line. These anatomic problems result from an overstretching of the anal sphincters, and a dissection started too low during the initial procedure. To manage his incontinence, we gave him a Malone appendicostomy for antegrade flushes, and he was able to be clean and socially continent, albeit mechanically. Now we present a novel technique for sphincter reconstruction with the hope that he will improve his ability to squeeze the anus closed and be able to have voluntary bowel movements. Here is a photo and an artistic diagram of what a normal anal canal looks like. Here you see him in prone position. Inspection of the anus shows a patulous anus and a missing dentate line. We performed a three-dimensional anorectal manometry, which confirmed objectively the absence of good sphincteric contraction, particularly on the anterior aspect. Here you see images of that 3D manometry. The operation begins in prone position. We place the Lone Star ring and pins to provide circumferential exposure of the anal opening. These are placed just at the skin level as there is no dentate line to preserve. The purple marks are placed at the mucocutaneous junction. Silk sutures are then placed in the bowel to provide for distributed tension for the dissection of the previous pull-through. We then start the dissection at the skin edge, trying to stay in the plane between the bowel wall and the surrounding sphincter muscle. The pins are replaced into this cut edge. The plane between the bowel and the muscle frees up easily as the muscle is not very adherent to the pull-through. You can see a nice areolar plane between the bowel and muscle and see the sphincter muscle circumferentially. This is the external sphincter. Once the pull-through is dissected circumferentially, the surrounding external muscle is easily visualized. These are the muscles that need to be more firmly attached to the distal pull-through to provide adequate squeeze to close the anus. If the patient can detect the presence of stool in the anal canal, they will be able to close the anus in time to avoid an accident. We plan to have the patient practice this during their antegrade flushes and anticipate they will get better and better at holding in their flush. Here we show the depth of dissection, which measures 3 to 3.5 centimeters. Deeper to this location is ischiorectal fat. The muscle is now tacked to the bowel circumferentially. We are starting anteriorly, which was the most problematic area noted on the manometry. The prior suture is tagged to show the ideal location for the next suture. These are absorbable sutures, forovicral, from the seromuscular bowel layer to the muscle. These stitches are placed circumferentially. Once all the tacking is complete, the sutures are cut. We then suture the mucosal edge back to the skin circumferentially. You can now see the anus is more closed. Digital exam confirms that the anus is supple and easily distensible, but now compressed by the surrounding external sphincter. After a period of time with continued antegrade flushes and with hopefully improvement in control, we anticipate trying to allow this patient to have their own bowel movements and to demonstrate their own capacity for voluntary control. Repeat three-dimensional anorectal manometry confirmed objectively an improvement in the symmetry of the muscles around the pull-through and in their increased tone.
For that, Emron, Corpus Christi. This was really a great technique. Would you change the position of the patient depending on where the sphincter defect would be, or would you put them always in that same position?
I really like the prone approach for redo HIRSCHSPRUNG, so I would utilize that approach. When we submitted this video, we didn't have data. That's now part of an article that we've submitted to associated with this. We've done this 6 times. 2 patients have behavioral reasons that they have not yet achieved bowel control, but we have really good results in 4. 2 of them are completely continent, not even using their Malone anymore, and 2 of them are still using their Malone on occasion. So what I think we've accomplished here is taken muscle that was there, but overstretched, and we basically just pulled it in and now reattached it in a more secure way to the anoplasty so that the patient is able to feel the stretch and squeeze those muscles and close the anus. So before this idea came to me, there was really no option for such patients except for antegrade or retrograde flushes. And now we can get some of these patients. Obviously, we need to avoid this problem completely. It's from overstretching and from losing the dentate line from starting the dissection too low. But there are patients suffering out there with incontinence for anatomic reasons and HIRSCHSPRUNGs, and I think we now have an option for them.
Thank you, Dr. Levitt. Would you caution against doing this if there's concomitant scar tissue? Unfortunately, I found that in post-op HIRSCHSPRUNG cases that weren't perfect, there's also a combination of scar tissue. And in your video, everything looked very beautiful. But do you have any advice with that?
Yeah, so I haven't encountered that in the sphincter destruction patients. But if there was a stricture, I would treat that like I would a patient who needed a redo for stricture and dissect out that scar and pull through until you had healthy rectum. And then at the end of the operation, tack the muscle in the sphincter reconstruction that you saw here.
Thank you.
Mark, do you want to comment on your workup until you get to this procedure? Like, when do you pull the trigger to do this procedure versus medical?
Yeah, thank you. That's a really good question. So when we evaluate a patient with Hirschsprung's disease who's not doing well for incontinence reasons, we do an examination under anesthesia. We want to know if they have a dentate line or an intact sphincter. 3D anorectal manometry is very helpful if your gastroenterologists have that modality. Standard anorectal manometry is okay too, and ultrasound is also okay, but 3D is beautiful. And then essentially those patients get a bowel management program. So either enemas from below or antegrade, depending on their choice and where they are in how independent they want to be. And I think at that point you say, do you want to try something else? Do you want Malone or enemas for life? Or do you want to see if we can improve your sphincter control? If it doesn't work, and I went into this with all these patients with that, this might not help, they still have a clean system. They're already successful with their Malone flushes. But what we then showed them is that with the continuation of the Malone flushes, they might learn some more control now that the anatomy has been changed. And to our happiness and surprise, many of them were then able to develop bowel control.
Great. Thank you.
Thank you.
Thanks, everyone, for a great session. Thanks to the speakers. Enjoy lunch.